Good evening, everyone. My name is Dr. Sarah Cole. I'm an orthopaedic surgeon based in Cairns, Queensland. Tonight we're doing one of our regular talks, and we have the great privilege of having Irene Egan, who is a physiotherapist, talk to us about hip pain, which we're going to cure in 1 hour.
Shortly.
Thank you.
Thank you, Dr. Cole, for having me today, and thank you for everyone for making the time and effort to be here. So my name is Irene Egan. I'm a physiotherapist working at Flex Physio Cairns on Martin Street, and I am an APA titled musculoskeletal physiotherapist. So I graduated from University of Queensland with a bachelor degree in physiotherapy in 2024, pardon. And then I went back to UQ and did my master's in musculoskeletal physiotherapy in 2019. And so I'm a member of the Australian Physiotherapy Association and a member of Australian Council of Physiotherapy. So after I graduated from my master's degree, I had the opportunity to work in one of the specialised hip and pelvis clinic in Brisbane, alongside with Dr. Alison Grimaldi, who had done extensive research and also education around the hip and pelvis. And so her particular interest is around the soft tissue related lateral hip pain. So why I chose the topic, because from my own personal experience, I find first hip and pelvis and spine is my interest area. Second, there is some complexity around how to get the correct diagnosis of that lateral hip pain. Where is it coming from? So my focus point to go into assessment and management today, I will be focusing on that soft tissue related lateral hip pain. But then beforehand, I'll talk about some key differentials as well. So what is lateral hip pain? So we know the location, the name of it. So generally localized to the region directly over the greater trochanter or immediately superior to it. So generally speaking, soft tissue related lateral hip pain, so it's when tendon and bursa around the greater trochanter is being involved, affects 1 in every 4 women around the age of 50 to 70. Other tissues, such as the hip joint, can be affected. So that we're talking about hip OA. And then we're going to more other complicated issues like hip dysplasia. And sometimes that can cause some lateral impingement around the area. That can give some sort of lateral hip pain. But they will sound quite different to soft tissue related lateral hip pain. Nerve tissues can get involved. And again, we'll go into the next slide and talk about some key differentials, how they might present. And then the lumbar spine itself, it could be the facet joint or the disc. Somehow can give patient that sort of description. I've got some pain coming into my buttock and my hip area. And so I think it's quite important to consider those sources, and then through our subjective and objective, we can form our clusters to increase our confidence what we're looking at. So I've got 3 key differentials here. So first is joint related pain. So this is typically hip OA, joint related, and I see a patient coming in, they grab it like this, they've got that typical grab, I've got this deep ache inside, the web here. And sometimes I may even describe this in the groin, a little bit out here, and a little bit in the buttock, around that region. So the area of pain gives you some idea where this source of pain might be coming from. Another really interesting fact from my own personal experience and some research have shown patients, sometimes with hip OA, they might present with a primary symptom of a knee and lateral shin pain. And these patients might walk into a clinic and getting knee assessed. Yes, they might have a bit of pain, and they might go down the route of getting a total knee replacement and haven't got any resolution of pain. Went back into clinic, having some assessment through the hip, super stiff, and going to hip joint provocation test. They might go, oh yeah, that's what I'm feeling, a real sensation in around the knee and the lateral shin. So what that tells us is if someone comes in, potentially we suspect, oh, knee pain, hip, let's have a look at the knee and hip together. Just quickly screen, what's your range of motion, what's the rotation like, so we don't miss that potential hip joint away. And often with the pattern symptoms, like for example, hip joint related pain, loading through the hip joint, sitting, standing, walking, single leg landing, walking up and down the stairs, that can typically give you more pain. And they often will describe stiffness, as we all hear, in the morning, I'm stiff for 10 to 30 minutes, and once I warm up, I'm a little bit okay. And in terms of 24 hours, they might get relief from rest. when I talk about rest, it's not exactly sitting, because again, we're loading up through the hip joint. They might be prefer lying down in a comfortable position with some pillow support. I had a really interesting client case in Brisbane, and he was actually a trail runner. He was running through different tree routes, up and down Macufa Hills, and he has got this event, and he wanted to do a big training. So he was hitting hard, and this man was middle-aged, in his 50s. In fact, does desk work, but that was his hobby. So he started this regimented, vigorous training regime. One day he was running through a really tricky track downhill through the trail training, and he started noticing some discomfort through his hip. And so he thought, I'll keep running on it might get better. Didn't take any notice, and ran on it, pain got worse, progressively got worse. So he thought, okay, I'll rest it. So he didn't run, rested, yet settled down. As soon as he went back to running, boom, it came on again. And he went to the stage that he couldn't run on flat ground for 10 minutes. That's when he came in, we looked at his hip joint, he was sort of in that room, and he did. He was like, it's in here, a little bit here, and I'm right through the body. And he had the scan done, and it was moderate hip OA. And I think it was just the amount of loading. And that sudden recent change in loading really affected and brought on that reactive phase of the hip OA pain. And again, with the hip joint related pain, people often will say, I sometimes notice myself walk with a limp. Or, my family noticed I start to walk with a limp. And there are some of those signs. In those subjective clusters, we start to piece it in a way. Okay, maybe it's more joint related rather than soft tissue related. Nerve related lateral hip pain. This is actually one of my personal favourites because it's so complex, but it has got a really interesting presentation if you're willing to listen to the person in front of you, how they describe and ask those questions and digging in. So if it's in a radicular presentation, often you will hear the person coming in, this like electric burning pain down my leg, and they go, where about? Is it here? No, it's like here. And it's very non-localized, and they will show you where it is. They might go down to my foot, and sometimes in some presentations they may not have that loss of muscle power, may not have the paresthesia, numbness that we expected. It could just have that pain. And then the aggravation could be sitting, there, boom, or standing, boom, and sometimes with walking as well. And they could get irritable at night, this group of radicular pain, depending how much you've done during the day. So again, it's quite different again, so you're picking up those signs that, okay, what we're looking at. And in terms of radicular presentation, the most common is they will have a radiculopathy, which often the L5 nerve root is being affected. That's when a neurological test, that's test for paresthesia, anything, light touch, sensation is preserved, muscle power. Sometimes I do a slump test to see how that nerve is like in terms of being stretched. That gives us a clue what we're looking at. But it will have a quite sort of different aggravation pattern to hip joint related, or again, we're in a minute talking about tendon related soft tissue lateral hip pain. Peripheral presentation under the nerve related pain. So this is when we have a lovely person come in, I may have some history of lower back pain, but I've got this ache around here, and again they rub it in circles, like around there. Can you pinpoint? Do you reckon you can use your fingers there? No, just around here. And they might say sitting for a period of time, again standing, not exactly hip specific movement will aggravate them, but probably more like posture related sometimes. That sort of aggravation giving them the ache. And in that case, when I start hearing that in my assessment, I definitely want to include a lumbar assessment. I want to see what the movement is like. I want to get on through the manual examination. Does that provoke this similar pain? And again, a slump test in terms of neural tension would be helpful to differentiate that. Now, my focus point is going to be the soft tissue related lateral hip pain. And but basically, is they will say, I got pain here, 2 fingers maximum, pain here, right there. And they might have some referral down the lateral thigh. Wouldn't usually go past the knee. And they wouldn't complain of numbness or paresthesia. Just go back to peripheral. Anyone familiar of the neuralgia paresthetica or the tight jean syndrome?
Strange.
Yeah, I know. I had a patient came in, and it was so interesting, and it was exactly that here, but it was numb. Her complaint was numb. Numbness, often with prolonged walking, standing, and sometimes they may or may not have burning pain, and that is a lateral femoral cutaneous nerve, and it's only a sensory nerve, so you wouldn't expect loss of muscle power with that sort of presentation. Just a note on the tendon pain, and I think I always like to ask those questions again, listening to the patient's story, and then I say, oh, I'm stiff, and I'll get up, I'll feel stiff and pain for the first few steps, but then I'm okay, and I'll walk for a bit. But then the longer I go, oh, that pain came on again, and that night I feel miserable. So that sort of, again, listening to those clues helped me direct with where we're heading. So what does the imaging say? So a study published in 2023, they looked at people with trochanteric pain and found 88 to 98% of cases present with some form of gluteus medius minimus tendon pathology on the MRI. So MRI so far is gold standard imaging for now, but I find diagnostic ultrasound has got and research have shown quite a good comparative efficacy in diagnosing gluteal tendinopathy as well. 20 to 30% of the bursal pathology with tendon pathology together, and very rare to have an isolated hip. So the bursitis only accounts for 2%. Again, just preempt, we're going to talk about the naming in a second. And then ITB thickening accounts for about 30% of the population. And this is quite interesting. This study they just thought, let's have a look at the asymptomatic population, people without any lateral hip pain. So 88% had increased signal on MRI around that greater trochanter, so the tendon above bursa structure, but they don't have pain. And 50% had glute tendon change. So it's quite interesting, food for thought for that, and how we're going to manage it, how we're going to educate it, how we're going to cure it.
So isolated bursitis is so rare. Why are doctors so keen to inject the GT bursa without addressing everything else that's causing it?
Such a good question. Very great question. We'll have more.
I think it's what's in their toolbox.
Yeah, and I think that's where I will go down the track of moulding all together. I think it's great to have the question, and I love to hear the conflicting view. It's how to come together, find the right one. And sometimes as clinicians, we want to offer what we think is right, but then I think at the end making that decision also with the person, the patient. So yeah, talk about terminology. So we like to use the word gluteal tendinopathy, we like to use the word hip-bursitis, and I think, habitually, and also with physiotherapy, we change how we manage and treat and name those conditions. We used to be quite structural driven, and with research, now we're like, oh my God, it's getting more grey. Well, we know for definite it's not exactly what we think it's right. And so I think from what the imaging stats and evidence that we looked at, I think now more and more people use greater trochanteric pain syndrome, GTPS, just because it's very rare to have just the hip-bursitis, and sometimes you might have the glute tendinopathy, but again, would that just account for someone to go in pain for treatment? So if it's combined, I think GTPS is more of a religion for it. So yeah, as I said, for assessment and management today, my focus point is going to be on this GTPS, greater trochanteric pain syndrome, soft tissue related. I like clusters. I like hearing those key, it's like playing Cluedo. I'm like, yeah, I tick, tick, tick. So they hate nighttime. They're absolutely miserable with sleeping. They don't like laying on their painful side and toss and turn. They go on the other side. It's like, oh, it's so painful. They're miserable. They come to you and they cry, please take my pain away. That's a key giveaway. But they wouldn't be our ridiculous patient though. Not like this pain, like relentless, they have to get up. Aggravated by walking, especially up hills and on stairs. Why? As we can see, standing on one leg, particularly that single leg loading, really aggravates them. Prolonged period of sitting. In a minute, again, in terms of management side, we'll talk about sitting component of it in more details. And they will feel stiffness and they go, oh, I get that pain. Like I said, when they first get up from the chair after sitting for a while, it's like, oh, a bit sore. Okay, I'm good now once they warm up. And they might say there's a recent change in the load. What that means is they might start a fitness goal. It's like, yeah, I haven't done exercise for a while. I'm going to hit the arrow walk. I'm going to go running. And they start doing a lot. And then they go, oh, I start to get this discomfort through the lateral hip. So that's another little clue. And I also sometimes find that changing load goes the other way because tendon is such a load, how would you say, load adaptive structure. It's so sensitive. It doesn't like too much. It doesn't like too little. There's a sweet spot. It's like a nice bell curve. So which the magic in terms of management is finding that bell curve for reversing. And again, looking at the person in front of us, as we know, 1 every 4 women in the age of 50 to 70. So are they in that menopausal transition period? Which part of their life cycle is at? Again, it might give us more of that clue. Okay, this might lean towards what we're looking at is the GTPS.
Still more men get it.
Oh yes, I will talk about the men. Mm-hmm. Yeah, they do. And I tend to, which right here, total hip replacement, and some parts, well, depending on a person's. Can we just go into past history? We'll
Could
continue.
be menopause too.
Oh, menopause. I like the term. True, right? Because I think all females.
Testosterone withdrawal and the hormonal changes post testosterone withdrawal. And you see a lot of these guys, most of my population of patients are older.
Yeah.
And prostate cancer, prostate hyperplasia, all sorts of stuff going on. There's loads of them.
Absolutely. There you go.
And you know the other trick is they all wear thongs.
Oh,
You've got to say thongs.
We will put that one other key features in our presentation. So again, I like to dive into the history of, or story, I should say, of their past history. So low back pain. And again, I have to say, digging into some research out there, because I always like to back it up, saying, okay, this is what I observed and felt, and like what was actually out there. So far, I don't think there's a direct link all research has done the exact causal effect of low back pain to potential GTPS right here. But from what I've observed from clinic and practice, what I tend to see is it could be the potential suboptimal motor control and how they bend because of that history of back pain, and then it could be overloading through their glutes, or sometimes underloading through their glutes, hence causing them more at a higher risk of getting the GTPS or experiencing it. ITB syndrome, so historically if they had presentational ITB syndrome, slightly put them at a slightly higher chance of getting GTPS. Hip and knee OA, and again, this is how we were saying about the low back pain, could be potentially just changing how they load. Could be that side, they have hip OA, and because of the limp and pain, they might overload on the contralateral side, or could be on the same side. And again, that predisposes how the soft tissue is going to be loaded through the area. And as Peter was mentioning about the male, it's in fact quite interesting. I saw quite a few male patients with greater trapanic pain syndrome after total hip replacement.
After.
Yeah, and obviously we know how you went through the lateral incision, as Sarah was talking about before, how we dissect the area. And I think sometimes what had happened is, could be, again, every person is different. Biology is different, and how they load up, what they do, how they exercise. I had a few male clients presented with GTPS after total hip replacement. Not immediately after, it could be they had it years ago and something had happened and they might present with that. Yeah. Spectrum of hypermobility. I find hypermobility fascinating. It's a big, not like for us, we always think about joint, ligaments, tendons, but it affects quite a lot of the organs, nerves, heart as well. So in Brisbane, again, I had the pleasure of working with a specialised physiotherapist specialising in Alice Damos and hypermobility, and we collaborate quite a lot. And we tend to see is with the population of being a little bit more hypermobile, they tend to load into those extreme positions because they can, and they go to yoga classes, they go, whoa, look at me. And then it's also that slightly altered joint position sense, not knowing, okay, that's too extreme, maybe the tendon's not going to like this, for a sustained period of time, repetitively, and that might predispose them to some more tendon related, especially for the hips. Look at our downward dog. It can very easily hang there. Yeah, so it's quite interesting. And I think tend to also help those patients understand, okay, there are some ways we can work around this, address the joint position sense, work through the deeper muscle group. Okay, clinical assessments, I find. So it's Alison Grimaldi, and it's a very great systematic review with meta-analysis published in 2023. Looked at the diagnostic accuracy of the current clinical tests of GTPS. So there are 6 here. First, we've got palpation over the greater trochanter, and we're looking for tenderness. Tenderness along the tendon, bursa. Second is the Trendelenburg sign. So this is a 30-second test to see a person's ability to maintain the hip balance. So we basically want to see, do a hip hitch out, or can they maintain the hip hitch? And it looks very much the same of the 30-second single leg stance test, but the aim of the test is different. So the 30-second single leg stance test is a greater trochanter pain provocation test. We are interested in terms of pain onset. We're interested in pain intensity. Whilst you're there, you definitely can have a look at their ability to perform as well. And then we've got the resisted derotation test in a hip flexion, adduction, and external rotation position. So basically, you're adding an isometric restraint. You ask the patient to derotate from that position, and you're looking for pain over the greater trochanter. Resisted hip abduction in an adducted position, which we wouldn't know this by the old OBIS test. Put them in there. But this one, you add the element of adding that resistance. And you want to see if, again, reproducing their pain over the greater trochanter. And the last one is Faber's test, flexion, abduction, external rotation. So first, palpation. As we know the anatomy of those tendon attachments, as we were just saying before, I think everyone is a bit different. Not exactly textbooks, textbook thinking, oh, this is what exactly everything's are. But I think from my learning is how big greater trochanter is. I think everyone thinks it's tiny, it's just right here. But 20 to 50 cent piece, again, every single individual is different. I think we just got to appreciate when we palpate, you want to explore around. So I often use a clock view, and I'm willing to hear how all of you do your palpation. I use a clock view because I don't want to miss the structures, I want to know where I'm at. So I'll give you an example. If we're looking at a right hip, we get the patient to lie on their left. And sometimes if they're really, really irritable, I put a pillow in between their legs just to be there so I can palpate through. And again, anyone to palpate through there, if any firm pressure, they will jump off the bed. So what I do is I gently put my hand on and I just use a bit of a pressure to see any difference along through different structures. So I typically go along the vastus lateralis up. I go through the lateral thigh, I come up, I hit the 6 o'clock. So again, if we're looking at that's the right hip, the 6 o'clock, the inferior side of the greater trochanter, and I explore around there for tenderness. I sort of come up to the 4 o'clock and see what that tendon, that insertion feels like. Then I go up onto the lateral facet and I explore through the gluteus medius tendon and around the bursa, the trochanteric bursa area, and see how that feels, any tenderness. Then I go, wow, yes, this is like my pain. And I go up, I directly go up to 12 o'clock for gluteus medius, and also gluteus medius, I've got a posterior portion and it's got a really thick stump tendon, anchor at that superior posterior facet. And I wouldn't go around there and have a feel what they're like. Are they thick or are they like really spongy? And then I come back, follow through to 1 to 2 o'clock for the gluteus minimus tendon, and keep coming, follow down through the 3 o'clock, so that's your gluteus maximus. And then if I'm really interested and I've got time, I go to the posterior side of it and finding out piriformis, conjoint tendon, and quadratus femoris. So that gives me a quite good indication, okay, where we're at and how are each tendon feeling. And most of the time, if someone's so sensitive, irritable, well, they might jump, but then you can compare, is this your most sensitive? Which one? And so that gives me a good understanding of what we are trying to address. And so what they found from the systematic review and meta-analysis is palpation is useful for ruling in and also ruling out. So which means, yes, you've got a really sore tendon, bang, it's painful, it's positive. But at the same time, we know on that tendon, it's not tender to belt pain. It's less likely to be a tendon-related pain. So I think it's quite important to know that in terms of palpation and spend some time. The Trendelenburg sign, so basically testing for inability to hold the hip hitch for 30 seconds. So hence, you hear people, the limp, they stand on the leg, they go, I swear my hip out. So that's what they're assessing. But again, this as a test itself is not useful for ruling in or out. But when we look at the 30 seconds single leg stance test for pain provocation, again, we recall the pain onset, pain intensity, it showed usefulness. If it's positive, it's useful for ruling in GTPS. But if it's negative, it's actually not useful for ruling out. So, whoosh.
Do you use the single leg squat to see how many reps they can do before they lose their pelvic control?
I do. I'm sort of more looking at it as a functional test.
Probably more than Trendelenburg.
And I would say, I look at my population. If I got a younger population who's more fit and just running, definitely want to lock them up in a single leg squat. But if I got a 70-year-old lovely gentle lady coming in,
they can do it.
Okay. And I guess it's also true, we shouldn't think they can't, but I think depending on the subjective.
When you can demonstrate the difference between the other side,
yes,
it really proves to them,
okay. I would love to be a 70-year-old.
That's my challenge for the next 6 months is to find a 7-year-old that I can do a single leg.
I know.
Come on.
Oh, challenge.
Video someone and see.
No, I want to see if I can do it in the show.
And I look for how many reps can they do?
How many reps?
Oh my God.
How many 7-year-old?
Standing on one leg and looking for control, you can do it.
Oh, that's
I didn't mean a full squat. This is a mini squat. This is a single leg squat.
Mini squat. I want a full pistol squat.
I just call that a single leg squat because it's what a lot of the exercise in sports do.
That's a good one. All right, I like that. Okay.
Love it. Next time, 70-year-old.
Yeah, I'm going to do it.
Resisted the external derotation test in theta position. It's shown to be useful for ruling in, not exactly ruling out. The resisted hip abduction in the adducted position has shown, from the research, shown to be useful for ruling in and ruling out. And Faber, you're not useful. You can have a look at it for comparison of the range, but if we're wanting to confirm our diagnosis for GTPS, sorry, you are not helpful. So as I was talking about the clusters, I'm big for clusters. What have I gathered from subjective? If I think GTPS is my primary hypothesis, all right, I'm still thinking about it, and despite I've ruled lumbar, I've ruled nerve stuff out, I'm coming to my diagnostic cluster from the clinical assessment. So giving you an example, if I got a negative palpation test, not tender, not around that area, maybe 10 through here, and I got a negative resisted hip abduction from the adducted position, as we know those tests are quite useful for ruling in and out, that increased my confidence of going, it's not, my GTPS is less likely to be my primary diagnosis. And if we like numbers, so again, from the subjective cluster, you're thinking I'm sitting about 59%, negative, we're down to 14%. On the other side, again, we've got the clusters, we're thinking after subjective, GTPS is our primary hypothesis, we've got a positive palpation test, we've got a positive resisted hip abduction test, it's going to increase our confidence. Yes, that might be good. And if, again, looking at the numbers, from 59, confirm, up to 96%. If you're not too sure, you want to go, I just want to make sure I'm ruling that in. Do a 30-second single leg pain provocation test. Starting a single leg squat, got time. It helps confirming GTPS, again, bring that percentage up higher. So it's very much, using those clusters and helping us to formulate, okay, what we're going to look at, increase our confidence, so then therefore we can offer correct management. I'm going to touch base on conservative management first, and I do have a slide of surgical repair as well. Thanks, Sarah. I just find it quite interesting, and I'm going to thanks to Alison for doing the research through LEAP trial, taking in patients with GTPS, and they looked at some different elements of conservative management and they compared. It's quite interesting. So we've got the wait and see group, we've got the cortisone injection, education and exercise. I find education so important. I think, again, from experience, I can give a person the best, fanciest, structured, beautiful exercise program. If I haven't talked about what not to aggravate, they're going to go into their life, sitting in a position, standing in their position, walk and run in that position that's going to aggravate their pain. I haven't done full service. So I drill in, I write drilling about education. Okay, you're painful, you're irritated, we're going to settle down the pain intensity. Before we commit to some form of really, really regimented exercise, I want you to stop doing some of this. Now you might show me, how would you sit, how would you stand, how would you walk? So first, sitting. Oh, lovely cross leg. It's great, we all do it, but if someone's really painful, they might not know. They might still sit in that position, and that's always that they notice. Oh, get up, oh my god, that's the side, I'm so sore and stiff. And so tell them simply, okay, for a period of time when you're so irritable with some people, how about let's reduce the amount of time you might cross your leg. And again, I find the type of chair, Alison tend to, and I do too, is something I notice is that everyone goes 90-90. And again, for hip joint, normal range of motion, 120 degrees, and depending how mobile you are, we're going to do a lower posterior tilt once we achieve that. So I find sometimes I just put a roll towel or wedge underneath their pelvis and lift them up a little bit. And they straight away will go and ask them, how do you feel? Do you feel any difference? They go, oh yeah, it feels not as intense in terms of their pain. So use a seat wedge or use some towels, be creative to elevate their pelvis. So education, minimization of pain aggravation, standing. I know we all do that.
Now, I wonder if that's why women get it more than men.
Oh, we carry kids.
Because they carry children.
Oh, yeah.
They carry children and stood there for years, holding a baby in one hand, doing things with the other.
Sure, just the hips
So this is all
back.
switched off.
Yeah.
And that carries through into later life.
Not only that, now the baby carriers. Oh, we're here. Anterior sway too. Yeah. So that's one of those things I do. I'll show me how you normally would stand. And they'll go, oh, and I often say, how do you find yourself at the kitchen bench when you're prepping dinner? I do this. Do you do this? And they go, oh yeah. And so there are some of those clues. And again, we're just picking up those clues and minimizing aggravation. Walking. Quite interesting. A lot of times when they come in, they'll go, I walk like this. I'm going to go for a long stride. I'm going to hide. And with that, because again, the long stride move is going to add more tensile and compressive load through the greater trochanter area. So go, you know what? You can still do fast, shorter steps. And again, softer landing, wide feet. And again, minimize the amount of uneven surface. If they decide to go for a walk on the beach, no, not for now, when you are so irritable and painful. And they want that. Because remember what I said, they're miserable. They can't sleep at night. They want to get rid of their pain. So I think that's quite crucial to understand. We're going to get some of your sanity of life back. Hence, sleeping position. Sometimes I tend to find for women as well, again, everyone's body is different. Everyone's pelvis size is different. They go, I already put one cushion in. Sometimes one is not enough. You need to do two. And that can be quite helpful. And again, we will have our lovely clientele comes in with the low back pain as well. So we've got to really consider what position helpful. They may not like to just lie on that side with two pillows. Sometimes they may not like to lie on their back with the two pillows. They might find quarter turns. So that's when you can explore, okay, how do you quarter turn from my own back, or some quarter turn from the tummy, just to at least get some comfort. They will thank you for that. But yes, I got some sleep. And what I also find is just some of that misunderstanding. There was a period of time, people go, oh, I've got this weakness to the side of my hip, we're gonna claim it. They do all this like open chain, woo, exercise, and realize if a person is already irritated through the retrotrochanter area, they in fact feel like after those exercises, they get more sore, they get more pain. And because of why? The ITB, we know ITB is so thick, and when they do those climb where they haven't got anything underneath, they're literally just adding more friction under this thick compression band of the ITB. So often we say, no clamp, thank you very much. You can do other exercises. And also that sort of ITB stretch we tend to do again is the compression and tensile load through the area. Yeah, education. Exercise program for some interest. So the LEAP trial, what they've done is a criteria-based exercise and they progress per each criteria. So they included isometric hip abduction, which is you're not physically loading it, you're in a position of relief, ease, you can lie on your back or standing, and you're just doing a gentle isometric contraction. So like contract, release, contract, release. Bridge progressions, you can start with 2 leg, offset it, which is a stage before you go to the single leg. Functional loading, like we said, squat, single leg squat, and stepping up. Again, that's one of those things we hear they're quite provoked from walking up and down stairs, single leg loading. And the last one is the frontal plane abductor loading with resistance. So the goal is to improve that frontal plane control of the pelvis, improve the general lower limb kinetic conditioning. And so what they've done as a program is they've done weekly for the first 2 weeks and 2 lots for the further 6 weeks. So it's a whole 8-week program. And I like this. We're going to ask them for effort, bulk scale. Because often if we give someone a strength exercise, we'll just give them, say, oh yeah, use this weight. But they might be at a lower effort, or it was actually too hard for them. So they use a bulk scale to monitor a person when they were doing those loading exercise. Usually you want to see about, like, say, 6 to 8. So that's effortful, moderately effortful. But the pain should be less than 5 out of 10. That's how they monitor in the program. And in terms of each exercise dosage, for the first 2, the lower load type of exercise, the 1 set of 10 daily. And for the more functional loading and then the strength training through the hip abductor, they've done 1 to 2 sets for 5 reps with a higher effort. So that's what they've done. And so let's get to some interesting outcome. So they got 204 people in the trial. Mean age is 55, 54.8, 82% females. BMI 27.5, and pain intensity, we couldn't see it there, but it's actually about 4.9, so 5. These people come in with moderately pain over the retrotrochanter area. Now this is interesting, you couldn't see it there. So median pain duration, 2 years. Oh, how can you put up with that? They're miserable. So that's the demographics, and so they grouped them, they randomized them into 3 groups. Wait and see, so did nothing. Just natural, see what happens. A single dose of cortisone injection through the bursa, or the area, and then we've got the education with exercise program. And so that's what I was saying, the 14 sessions over the 8 weeks, as I explained before. So the 2 primary outcomes. First is a global rating of change. I want to see, hey, how do you feel through this program? How much do you reckon? Are you much better, moderately better, not much better, or no change? And then the pain intensity. So if we look at the education exercise group, at 8 weeks, 77% of the people achieved moderately better. And at 52 weeks, 78% continued on moderately better. Single dose of cortisone injection, at 8 weeks, 58% achieved moderately better. At 52 weeks, 57%. Around there. And for the, hey, wait and see, let's wait this out. For 52 weeks, 8 weeks, definitely you can see 29% say they are moderately better, but at 52 weeks, they are 52% saying they're moderately better. Yes. Gotta love the nature, human body. And as for pain, so they're using the numeric rating scale, 0 no pain, 10 was pain manageable. For the exercise and education group, on average they achieve 1.5. That's their pain rating at 8 weeks, 52 weeks 2.1. Cortisone injection group 2.7 for their pain intensity at 8 weeks, and 52 weeks 2.3. And with the lunacy, we're sitting at about 3.8, 3.2. And so, yeah, in a nutshell, yes, exercise and education is more successful from the work rating and change and pain intensity, short term and long term. But sometimes with that long term, as we can see, those group of people, they had an average or pain duration of 2 years. The study didn't do a 2-year follow-up. What I like, which is very hard for research. We don't know. And for the cortisone injection group, research have shown there's some side effects to tendon health, and definitely repeated use of cortisone. And some of the study have associated poor prognosis. I personally think, so there is a role in cortisone injection. I feel like if it's standalone, if the person goes, okay, I'm just going to get that injection, I'm going to have a magic cure, I'm going to be all good, I think that may not be realistic. But if a person is so irritable, they can't move, and we've tried it, then they're not going to budge. And I think there is a role in terms of offering them that sliding door moment of getting that intensity dampened down. But then we go, okay, this is your chance. Let's do some exercise. Let's address the area. Give them the buy-in to do the education, do the exercise. And I think that use is better than, because usually I think the wear-off time is about 6 to 12 weeks, depending on the individual. Depends. Yeah. Quite interesting. They looked at 2 different exercise programs. So as I said, one is a criteria-based, one is a stage-based, but they go through different muscle groups. One's called the Globe, one's called the Leap. And what they found is the Leap trial achieved a higher percentage of improvement from patient-reported outcome measure. And why could that be the case? Even though both group got comprehensive education, no stretching, they've got close-chain weight-bearing exercises, the Globe had no heavy loading. The Leap have got the heavy loading. So one difference. And also another difference is the Leap included that loaded frontal plane control, and it's got specific movement training, like the squats variation, the step up, whereas the Globe didn't. And another interesting part is how the program was delivered. So the Globe is unsupervised, independent, at home, you do it yourself. One is you have to go to a clinic, you've got to get supervised by physio and do that 14 sessions over 8 weeks. And then the compliance percentage is different as well. So again, I think this is when we go, okay, we've got this research, how are we going to address and give it to the person in front of us, which one is more suited? Other management, shockwave therapy, haven't found much of a higher level of evidence. Does anyone use shockwave therapy here? No? Okay. Yeah. And again, it's one of those things, personal preference, and what they found from research so far from, I think, greater like again, I'm talking about what we're looking at GTVS here, is associated with some pain and some bruising afterwards. And there's a cost involved as well. I love the hormone therapy. Now, infancy, only done by females so far, only one study used as an adjunct with exercise and education, and they put a cream over it. And so they showed the individuals with a lower BMI had a better outcome. So again,
they might have less endogenous estrogen if they're following it.
Yeah, that's it. It's a very infancy side, and I think I can't wait to see more, and especially with the male populations as well.
I've seen
Is that
them.
with the cream or
Yeah, right.
Is that right?
I've seen them up there with their tendon tears.
Oh,
You've seen what?
People with tendon tears.
putting creams on that.
Not using creams, no.
Oh, okay. Injecting? So surgery. Some open, some endoscopic glute tendon repair. So let's look more in terms of surgical repair, as Sarah and I was talking about it. This is so fascinating. Again, so this study was published 2023. So this group of orthopedics that went through people going through the surgery, success, failure rate. And they go, okay, let's find some prognostic factors. If we can set up a criteria, can we predict, are they going to be successful? Are they going to be not successful? So some of the findings is the extent or the grade of tendon tear, going from partial, full thickness, with the different centimeters of contraction, smoking, psychiatric history, or mental health, back pain again, hello! And that's one of those things I was talking about before, so I love it. It's one of their prognostic factor to look at, and antalgic gait. So then they number them in terms of points, so set up as a 7-point scale. So what they found from this study, if it's an individual, so somehow they scored less than 2 out of 7, they're going to have success from the surgical repair. If the person scored equal greater to 4 out of 7, was associated with risk of failure. But it's quite interesting how we define success and failure. Is they use a patient-reported outcome measure. So not what we think is a structural attachment. They use a patient-reported outcome measure for global rating of change. Do you reckon this is addressed your problem? And they found there was a 21% failure rate. So yeah, and I think this is one of those things we could discuss with the patient if they were considering going down the route, or asking, is this something to repair my tendon?
One of the difficulties with surgery, because they use anchors to anchor it down. With the rotator cuff, you would immobilise and you take the load off. What do you do with the GT that they're reattaching with anchors and tendons back to the GT? You can't immobilise.
And I think that's why the high risk of failure.
You can't take the load off because you're asking that repair to fail. The sutures are just going to pull through the tendon tissue.
So you can't even, so you can put them on crutches, but then what's that going to do?
They're still going to stand on from time to time. As soon as they
Sitting.
put a load on it,
Yep.
like with rotator cuff repairs, you don't want them really doing any load
That's
in 12
right.
weeks.
That's right.
How do you, it's begging for failure.
Key takeaways. Finding the right diagnosis. Don't be fooled. They might have a bit of this and that, but I know which one is their primary source. Finding, using the subjective and objective clusters, increasing confidence. Taking the active approach first. Education, exercise. Let's give that a try first. If all fails, okay, let's continue that conversation of what else is out there. Cortisone injection may help reduce pain intensity in the short term. It can be buying for someone. But funny enough, as we see from the research, is no better than wait and see in the long term. Higher number of previous use of the cortisone injections, failed conservative management. Let's think about surgery, and with the surgery option, that's again, think about those things that we just talked about. Can we completely offload after the surgery? What are their prognostic factors are? Are they going to succeed? What's the patient? What do they want out of it as well? So there we go. Thank you for your time.
I'm sure everyone's got questions. My first question is, you talked about the relationship between low back pain and gluteal, or what did you call it? Greater
Pain syndrome.
Yep.
Yeah.
My question really is, what do you think about the relationship of low back stiffness and greater traumatic pain syndrome as opposed to just low back pain? Do you think, I always tell myself it's the stiffness that's the problem, but...
Absolutely. I actually tend to, so when I see a patient with back pain as well, I love to see how they naturally sit, how they naturally stand. So there's a group of clients, if again we're going to use the criteria, is called the extenders, like hence sometimes they might feel stiff, and that's how they would naturally lock up in that stiffness, and therefore if you need to go into any form of bending, you wouldn't have the lumbar flexion, pelvic flexion, you will use all your hips. And what that will do is straight away we're going to add repetitively more load through that gluteal tendon area.
You were just talking about surgery, and I guess what I'm looking for when I'm considering operating on them, which I don't do very often because I think that, as you say, a lot of it is much better served with physiotherapy. What I'm looking for is that real weakness, and I guess my question for you is, if you see significant weakness, at what point do you say, well, maybe this is something I'd refer, as opposed to, so sometimes they have weakness because they're sore, and sometimes they have weakness because it's torn. Do you have a way of sort of distinguishing how you want to manage either of those conditions?
And I think you addressed beautiful there. There's so many factors can contribute to weakness. Like you said, is it pain and condition or is it neurological? I want to be definitely sure, right? Because sometimes it's quite rare to just have isolated. So with that weakness, again, is how the person, again, the person in front of me, what their age group, what they want to achieve. Do they just want to achieve something like, I want to be able to walk a certain amount of time? I would start them off a tailored program and could be starting from that criteria based. And I want to assess them what their impairments are. So that's when I know, okay, if we've confirmed with the diagnosis, what are your impairments? Is it because you're very weak here, but what about your hip flexors? What about your lower glutes? What's your core doing? Are they functionally addressing all areas? And if I'm exhausted, like I can't make a change, and sometimes it could be those little life positions or the tasks innocently that I think, oh, that's the right thing to do, and but just grabbing that, and I want to see if that then will change their weakness. Because sometimes it could be like that subjective feeling of weakness comparing to that actual like, oh my god, this is like loading this, you just absolutely cannot do it. Yeah. That's how I would approach it.
Yep.
Yeah.
Good.
Do you go much for open chain
Ooh.
as opposed to closed chain?
Depending on my client. If I've got a dancer, I would. So usually the one, because I think open chain I tend to find it just fire off quite a lot of the TFL and ITD, which again, it's really depending on that person. I like starting with closed chain because it's got that stimulation, we're going to get the deeper muscles working. Yes, joint proprioception, like joint position sense. But if I've got a dancer, I've got a circus performance, I've got aerial skier, if they have to do that open chain, I'm going to train them in that. And I need to address that.
So your bog standard patient that isn't an elite performer, the straight abduction, straight leg raise, more sort of posterior and internally rotated, isn't something you classically use a lot.
I actually get them to do side stepping, get them to slide. I want that weight bearing, and I'll often teach them. I'll go, okay, I want you to feel the loading on your left. So I want you to think about push down and away from you as you step to the right. I often get them to do the upright, feeling comparing to with a mini bend. That's how I would get them to load up through that area. Because I often find it's much better at getting them to feel the area. Don't get me wrong, I've done that before too. I totally did the claim too. And then I think that's when I start to reflect from my own experience and how much do I get out of that. And if I then ask, and I'm the type of person who go, where do you feel it when you do this exercise? If you're like, no, I want it here. And I'll find a way for them to address that area. Yeah, so that's my...
Crab walk around the knee. and around the knees,
Yeah.
progress to the ankles and you'll feel your butt.
Yes, and I think if we go back to the slides, in that LEAP trial, they really focused on that loading, that frontal plate, which is really hard to achieve without a slider or reformer. So that's when I go, oh, if you got a reformer, perfect, let's use it. How can we get you up? That's the perfect way to load heavy to get them to feel that sort of movement. But if we don't, sock, TheraBand, let's do a version of that. Yeah.
Have we got any questions online? Do we have any? Oh, we've got the chat. Just check the chat. We have Shockwave, says Kate Bennett, but haven't used it for greater trochanter.
Oh,
Veins
yeah. Yeah, Shockwave.
I'll take that there's no more. Well, thank you very much. Like I said before, this is the part where we turn off all the screens and ask all the real questions. So thank you to our Zoomers, and thank you on Facebook, and have a good night.
Thank you.